and welcome to ACR Journals on Air podcast. I'm your host, Vicky Shamagam. We've all been there, standing at the bedside, evaluating a patient with aggressive scleroderma, and making the recommendation of an age-appropriate malignancy workup. And I'm going to guess that I'm not alone in wondering why. We know there is an association between scleroderma and malignancy, but what's the connection? And is there any way to stratify patients to assess their risk and identify those who merit a more extensive workup? The manuscript we will discuss today is Distinct Scleroderma Antibody Profiles Stratify Patients for Cancer Risk at Scleroderma Onset and During the Disease Course. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures are in our show notes from today. I'm delighted to be joined by the manuscript's senior author, Dr. Ami Shah. Dr. Shah is Associate Professor of Medicine and Director of the Division of Rheumatology at the Johns Hopkins University School of Medicine. Dr. Shah graduated from the Massachusetts Institute of Technology and Johns Hopkins School of Medicine. She then completed her internal medicine residency at Stanford University and returned to Hopkins for her rheumatology fellowship. She earned her Master's of Health Science in Clinical Investigation at the Johns Hopkins Bloomberg School of Public Health. And Dr. Shah is an outstanding physician scientist. Her clinical practice focuses on scleroderma and related disorders, and she's been working for years to understand the complex interaction between scleroderma and underlying malignancies. She's a wonderful human being and a fantastic academic leader. Welcome to the show, Ami.
Thanks so much, Vicky, for your generous introduction and for the opportunity to speak about the link between cancer and scleroderma.
So, Ami, can you get us started by giving us some background to this study? Although we always worry about malignancy when someone presents with new onset scleroderma, not all patients are at risk. Some antibody profiles carry higher risk than others. Tell us about that background and what hypothesis were you trying to test with this particular study?
Sure. Well, it's long been recognized that in a subset of patients, we can see cancer and scleroderma emerge together in time, much like what we see in patients with dermatomyositis. The co-occurrence of these events raises the question of whether cancer is triggering the development of autoimmunity. In prior studies, our group identified that scleroderma patients with anti-RNA polymerase III antibodies have an increased risk of cancer around the time that they're developing the first symptoms of scleroderma. When looking in cancer tissues from these patients, we found that there were genetic alterations in genes encoding the same scleroderma autoantigen in the cancerous tissues. We also found that these patients had evidence of mutation in wild-type peptide-specific CD4 T-cell immune responses and the development of cross-reactive autoantibodies. These data suggest that mutations in autoantigens in cancer could induce an anti-tumor immune response. If this immune response spreads, it could be beneficial and have an anti-cancer effect, but also lay the groundwork for the development of autoimmunity in a susceptible host. So these data raise several really interesting questions. Could scleroderma autoantibodies be biomarkers of an underlying cancer? Could they be useful tools for cancer risk stratification? And if patients with RNA polymerase III antibodies have a higher risk of cancer, why do we see cancer emerge clinically in 20% of cases and not in the other 80%? Could it be that cancer is a trigger of scleroderma in all patients with RNA polymerase III antibodies, but that the immune response is successful in eliminating the cancer in some patients? In a series of studies, we've been exploring these questions and have shown that scleroderma patients with RNA polymerase III antibodies who also have other autoantibodies, either to RNA polymerase I or THTO, are less likely to have cancer emerge, suggesting that the development of a broader immune response could be cancer protective. So in this particular study, we were interested in exploring these ideas further. Could a panel of immune responses, either alone or in combination, help us better risk stratify patients for cancer around the time of scleroderma onset or during the disease course?
I love it. So the immune response is not always bad. So that makes sense, but scleroderma is a rare disease. You pooled 2 study cohorts in this particular study. Can you tell us about those 2 cohorts and what was the benefit of analyzing them together?
Yes, in this study, we collaborated with Dr. Robin Domsick and included patients from both the Johns Hopkins and University of Pittsburgh scleroderma cohorts. We designed this as a case control study where we included cancer cases from both centers and scleroderma controls who did not have a cancer diagnosis after at least 5 years of disease. We systematically tested banked sera from these patients for 11 scleroderma autoantibodies. By pooling data from 2 centers, we were able to study over 1,300 scleroderma patients, 676 of whom had a cancer diagnosis. This large sample size was critical as it ensured that we had enough statistical power to examine the relationships between cancer, especially cancer around the time of scleroderma onset, and the 11 autoantibodies individually and in combination.
So, next, I wonder whether you could review for our listeners the nuances of defining age of onset of scleroderma in studies. Why do studies list both the age of first non-Raynaud's symptom as well as the age of first symptom of scleroderma, whether it be Raynaud's or something else?
Yes, in scleroderma research, we're often trying to determine when the disease began based on a patient's report of when they first noticed Raynaud's phenomenon or other scleroderma symptoms such as puffy fingers or skin thickening. Defining disease onset can be helpful when we're trying to study the co-occurrence of events like scleroderma and cancer, but also when investigating whether certain complications are more likely to occur earlier versus later in the disease. From a clinical standpoint, this can help us identify windows of time when patients may require closer monitoring for different organ systems. In this particular study, we defined scleroderma onset as the first of either Raynaud's or the first non-Raynaud's scleroderma symptom.
And tell us about the cancer definitions you used in this study. How did you define cancer-associated scleroderma?
We ascertained whether a patient had a cancer diagnosis using several methods, including patient report and through query of our electronic medical record systems data using diagnosis codes. We then validated each cancer diagnosis and its date through medical record review, including review of pathology reports and oncology records. In this study, we defined cancer-associated scleroderma as cancer occurring within 3 years of scleroderma onset, similar to definitions that are widely used for cancer-associated myositis.
Okay, and the scleroderma antibodies are a little bit of an alphabet soup. Would you mind reviewing for our listeners the antibodies you tested in this research and why did you select them?
So we tested for 11 scleroderma autoantibodies. These were antibodies to centromere, SCL70 or topoisomerase 1, RNA polymerase 3, THTO, NOR90, U3-RNP or fibrillary, COO, Rho52, U1-RNP, and RNPC3. And these were tested using the Euroblot1 assay and commercial and custom ELISA assays. We chose these antibodies since they are known to associate with distinct clinical phenotypes in scleroderma, and for some of these, we had preliminary data that they associated with cancer risk or protection, like RNA polymerase 3, centromere, THTO, and RNPC3.
Okay, so let's talk about your results. In those cohorts, how many patients did you have who had scleroderma and cancer? And of those, how many had your definition of cancer-associated scleroderma? And then follow up to that question, which cancers were most common in your cohort?
So there were 676 patients who had scleroderma and cancer when we pooled across both cohorts. And 112 of these patients had non-melanoma skin cancers. So we included them in secondary, but not our primary analyses. The 3 most common cancers otherwise were breast cancer, lung cancer, and hematologic malignancies. And these accounted for about 50% of the cancers that we saw. And cancer-associated scleroderma occurred in approximately 25% of patients who had cancer.
So tell us a little bit about those 2 cohorts. Looking at baseline characteristics and demographics, you found some important differences in the patients with cancer versus those without. Tell us what you found.
So patients with a history of cancer were older when they developed scleroderma than the group of patients without cancer, with an average being about 48 years versus 40 years. Those with cancer were more likely to self-identify as being white race, and they had a slightly shorter follow-up time, an average of 7.6 years instead of 9.2 years. There was also a slight enrichment of male sex, a history of smoking, and interstitial lung disease in those who had a history of cancer.
And you did some statistical modeling of the individual antibody associations and then adjusted for other factors like age, sex, race, smoking history, scleroderma subtype. Can you walk us through that analysis and tell us what you found?
Sure, we performed separate analyses for cancer at any time point and cancer-associated scleroderma, where the cancer occurred within 3 years of scleroderma onset. For cancer at any time point, we found that anti-RNA polymerase III antibodies associated with a higher risk of cancer and anti-U1-RNP and anti-centromere associated with a lower risk of cancer. These findings persisted when we adjusted for age at scleroderma onset, sex, race, subtype, and smoking history, but the findings were somewhat attenuated. When we examined cancer-associated scleroderma, we found the exact same signals, but with a greater magnitude of effect. In our adjusted models, patients with RNA polymerase III antibodies had a 2.3-fold increased risk of cancer-associated scleroderma, and those with anti-centromere and anti-U1-RNP had a 61% and 68% lower risk, respectively. We also saw a signal that TH2 was protective of cancer-associated scleroderma with a 59% lower risk.
You also found something quite interesting related to the Ro52 antibody. Is that right? Can you share that with our listeners?
Yes, anti-Ro52 is a really interesting autoantibody since it was present in about 30% of our patients, but it commonly co-occurs with other scleroderma autoantibodies. When we examined any Ro52 positivity, we did not see an association with either cancer risk or protection in scleroderma. However, when we looked at whether patients were positive for anti-Ro52 only, we saw that monospecific anti-Ro52 antibodies associated with a 2.2-fold higher risk of cancer at any time point and a 2.6-fold increased risk of cancer-associated scleroderma in our adjusted models. This was really interesting to us as there is a small literature suggesting that anti-Ro52 may be a cancer biomarker in other rheumatic diseases, and anti-Ro52 antibodies have been seen in cohorts of patients with different tumors, with some data suggesting that cancer patients who have anti-Ro52 have better cancer prognoses.
Super interesting. Okay, so take us now to figure 2, which is your beautiful random forest decision tree. I want to make a joke about not being able to see the wood for the trees, but tell us what the purpose of the random forest model was and how can we put this to use in practice?
Sure. Well, in this study and in others that have been done in scleroderma, myositis, and lupus, there has been data accumulating that having a higher number of different autoantibodies may associate with a lower risk of cancer than what you see in the rheumatic disease cohort or what you would expect compared to the general population. While it's interesting to look at numbers of positive autoantibodies, we saw in our analyses that some autoantibodies associated with a higher risk of cancer and some with a lower risk. And autoantibody count really doesn't take into account the directionality of these associations. So it's more clinically informative to look at specific combinations of autoantibodies that associate with a higher or lower risk of cancer. And that's what the random forest analysis allowed us to do. From the random forest analysis, we learned that having anti-RNA polymerase III or having monospecific anti-Ro52 was associated with the highest cancer risk. Patients with anti-Ro52 who also had anti-TH2 had a moderate cancer risk, as did patients who were negative for RNA polymerase III, centromere, and Ro52. And patients with anti-centromere or those with anti-Ro52 plus U1-RNP had the lowest risk of cancer. The random forest analysis is modeling predicted probabilities of cancer using this case control study design. So we have to keep in mind that these results do not speak to absolute risks of cancer in a general population of scleroderma patients, but the results do suggest that measuring a panel of 5 scleroderma autoantibodies could be a powerful approach to risk stratify scleroderma patients into those who have a low, moderate, or high risk of cancer.
That's great. And I'm going to ask you to speculate a little bit now. So are you able to hypothesize about what all this data might mean mechanistically? Are some of those antibody profiles telling us something important about cancer biology?
Yeah, thanks for that interesting question, Vicki. In the last decade, there has been emerging literature suggesting that cancer and naturally occurring anti-tumor immune responses may be a trigger for the development of diseases like scleroderma and dermatomyositis. We think about this mechanism in patients with anti-RNA polymerase III antibodies in scleroderma and anti-TIF1 gamma antibodies in dermatomyositis. However, not all of these patients have a cancer diagnosis. So if you look at patients with RNA polymerase III antibodies, 80% of them do not have a cancer diagnosis. Could it be that subclinical malignancy is a trigger for the development of autoimmunity in these patients, but broadening of the immune response is exerting a potent anti-cancer effect? If so, that would have very important implications, not only for how we screen patients for an underlying cancer, but also when considering therapeutic options for both scleroderma and cancer.
Thank you. I feel like that is such an interesting line of work, and I really want to thank you for sharing your work with us, Ami, today. I'm going to take a different path through the forest with you now, because listeners love to hear about the person behind the paper. And so I wondered whether you could share some stories from your career. For as long as I've known you, you've always been a sclerodermatologist. But what got you started in this field?
Yeah. Well, in medical school and early residency, I actually thought I was going to be a cardiologist or do critical care or GI. But in December of my second year of my internal medicine residency, I had a mandatory rheumatology rotation. And I immediately became fascinated by the complexity of multisystem rheumatic diseases and the different clinical phenotypes I was seeing. And every evening I would read about these interesting cases I had seen and try to learn what was known about the underlying biology and the very clinical manifestations. And every day I would meet these incredibly resilient patients, some who reported a dramatic improvement in their quality of life with new therapies, and many who were just so grateful for the relationships they had with their rheumatologists who gave them hope for the future. So within 3 weeks of starting that rotation, I realized I wanted to be a rheumatologist and started applying for rheumatology fellowship. It was by far the fastest career decision I've ever made. And when I came to Hopkins for rheumatology fellowship, it was really seeing patients with Fred Wigley that motivated me to focus on patients with scleroderma. With each case we would see, he would talk about the clinical manifestations and ask questions about what the underlying pathogenesis could be. Each patient was teaching us something and was the source of numerous clinically meaningful scientific questions. Fred is really an amazing clinician and scholar, and his intellectual curiosity is just infectious and energizes everyone around him. So that's how I got started in scleroderma and ultimately in studying the connection between cancer and scleroderma.
That's a fabulous story. Now, you've had a fairly traditional physician-scientist pathway. Tell us about that journey. How did you find your way, and which mentors influenced you as you've traveled?
Yeah, so during my time rotating with Fred, I started pursuing a few research projects that arose from those clinical encounters and brainstorming sessions we had. And during my fellowship, I was able to pursue formal training in clinical research methods through the Johns Hopkins Bloomberg School of Public Health. But I think one of the most important factors in my journey was that I was surrounded by these incredibly generous and supportive mentors who nurtured me and invested in me. Anthony Rosen, who was the director of our division of rheumatology, has really had a profound impact on my career. He taught me how to take a step back from a patient to see the big picture and how to ask these deep, hard, and impactful questions that can translate into scientific leaps. Livia Cassiola-Rosen and Laura Hummers have also played a major role in my scientific and career development. It's been wonderful brainstorming ideas with them and thinking critically through study results and what they may mean, but they've also been incredible friends, confidants, and role models who are simultaneously growing and nurturing their families and their academic careers. So I've just been incredibly lucky to have such amazing friends and mentors.
And you now have a K24, which is, for those who don't know, an NIH grant through which you mentor others in the scleroderma field. Tell us about that work and what are you doing to give back?
Thanks. Yeah, I'm really fortunate to have this K24 award that allows me to focus on mentoring young investigators. And that's the part of my job that I find most fulfilling and fun. So it's wonderful to have this mechanism. The scientific goals of that grant really tie in with our personalized medicine initiative in scleroderma and draw upon many of the lessons we learned while studying the relationship between cancer and scleroderma. So we know that scleroderma is incredibly heterogeneous in terms of a patient's symptoms, the trajectory of a patient's disease, the timing of clinical events, and how patients respond to different therapies. So, one approach to addressing that complexity is defining subgroups of patients that are relatively homogeneous, as patients with similar disease features may share underlying disease mechanisms, risks of complications, and response to different therapies. So, in part of this grant, we are developing methods to generate personalized risk estimates for multiple scleroderma complications by harnessing a patient's own longitudinal data along with the data and known outcomes from other patients who share similar clinical characteristics. We've developed a data visualization and analysis tool that illustrates a patient's trajectory in many organ systems compared to all of the other scleroderma patients we've seen. And we're testing the value of embedding those personalized predictions into the tool to improve medical decision making. We're also using subgroups of patients to identify biomarkers that may associate with disease progression in scleroderma.
That's such important work. I'm so glad that you're leading that initiative. So a few years ago, I think probably right in the middle of the pandemic, you became director of the Division of Rheumatology at Johns Hopkins. It's an enormous division. Tell us about that role. What have you learned? Do you have any advice for others who might be stepping up into leadership roles?
Yeah, thank you. I'm incredibly honored to serve as the director of rheumatology at Johns Hopkins. We have a really amazing group of faculty, trainees, and staff who are doing wonderful work, really committed to outstanding patient care, driving innovative scientific discoveries, and training the next generation of leaders in academic rheumatology. And it's just wonderful to be in a role where I can contribute to enabling that work across all of those important missions. There are several things I've learned in a short time that might be helpful to others stepping into similar leadership roles. One lesson has been that it's important to draw upon the strengths, wisdom, and diverse perspectives of your team when you're trying to identify key challenges or unique opportunities and potential solutions. So early on, I met with each of our faculty to understand what they were really passionate about and what brought them meaning in their work lives, but also what was challenging and making their day-to-day difficult. And in some instances, these were colleagues I'd known for 15 years, but I still learned so much from each person. So some common themes emerged from that exercise about what makes us special as a rheumatology division, where there were opportunities for us to innovate, but also which problems and barriers should be tackled that would allow everyone to do what they do best with greater ease. It's also important to learn the perspectives of every person on your team, regardless of their roles. We had a wonderful strategic planning retreat with over 100 division members attending, and it gave everyone, our staff, our trainees, and our faculty, a voice in shaping our future. Another lesson I've learned is that it can be incredibly powerful to harness data for decision making and to advocate for the importance of our field and our work within our institutions. And that data can come from within your own group, things like clinical productivity and compensation, but also from our colleagues in academic rheumatology. I've called other rheumatology division directors to learn from them. How do they run their divisions? How do they support their clinical practices? How do they navigate different challenges? I think we're incredibly lucky to be in a community where people are willing to share their experiences and help our field thrive as a whole.
Yeah, and that the cohort of rheumatology division directors around the country are an incredibly strong resource, a brain trust, if you will. So, Ami, I wanted to thank you for joining us on the show today. I always enjoy hearing you talk about your work, and your career is a real inspiration.
Thank you so much, Vicki, for providing me with this opportunity. It was really lovely chatting with you about science and about life in academic rheumatology.
Our thanks today also go to our patients. Advancing the science in rheumatology really begins at the bedside, and it would not be possible without the trust and commitment of our patients, donating samples, filling in symptom questionnaires, asking questions, and helping us see the forest through the trees. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.